Coming up today, skin cancer that came back, then came back again. How one mom navigated the recurrences without chemo or radiation. Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Skin cancer is the most common cancer in the U.S., but melanoma is one of the most aggressive and deadliest forms of it. In 2025, the American Cancer Society expects more than 100,000 people will be diagnosed with melanoma, and nearly 8,500 people are expected to die of it. For one Kansas woman, a small spot on her arm turned into the fight for her life.
Ashley Graver has always enjoyed her time in the sun, and protecting her fair skin has always been a priority. So when she noticed something, she said something to her doctor.
I had noticed a spot on my arm, and it was black and looked weird.
It turned out it was melanoma, an aggressive form of skin cancer.
I did a lot of research, met with a Mohs surgeon and a surgical dermatologist who removed it, and he did the wide excision where he takes a lot of the margins around it. And they got clear margins, so there was nothing further that needed to be done at that time.
Ashley thought it was behind her and was concerned it was going to affect the fun part of life and her time with her family.
I was a little worried about, what does this mean for my vacations? I like to go to all-inclusive resorts. Am I ever going to be able to do that again? So I thought, I'll have to change the way that I live.
A decade later, the cancer was back.
It was 10 years later, and I felt a tender spot in my armpit.
Her cancer was back and had spread. It was a complete shock to Ashley.
I had no understanding that a recurrence of melanoma could happen internally. I thought that was it was another skin episode. Everybody has told me you're at a higher risk for recurrence because you've had melanoma before, but I just assumed that was another skin episode and that I would see it.
She was referred to medical oncologist Dr. Larry Corum at the University of Kansas Cancer Center in Olathe. He started Ashley on immunotherapy.
They were using it either for stage 4 or in clinical trials. And so it was relatively new that someone in stage 3 like myself could be eligible for immunotherapy. But after the resection, we went ahead and did that for a full year.
However, 5 years later, the cancer came back again. But with continued immunotherapy treatment, Ashley remains hopeful. Since her treatment with Dr. Corum, Ashley is in medical terms what's called NED, no evidence of disease, which is extremely rare with her type of cancer. She credits her team of doctors and her special team at home. On the same day Ashley received news her cancer had returned, she found this message in her daughter's school bag.
Hope motivates us to keep going even when things seem impossible. And it was like a message that I needed.
And we are so happy to have Ashley Graver with us in studio this morning. We are also joined by Dr. Larry Corum, Ashley's medical oncologist, joining us from the University of Kansas Cancer Center in Olathe. Dr. Corum, good to see you.
See you. Good morning.
Good morning. Well, Ashley, going back to 2008, you had this spot on your arm, and I remember you telling me you actually thought that dark spot that we saw there on the video was a piece of gravel, right?
That's right.
It was so unusual. Tell us about that.
I had been in an accident a couple years prior, and so when I saw that on my arm, I just thought it was something trying to work its way out of my skin, but it started bleeding a little bit and just was concerning to me.
So what made you decide to go seek a doctor?
Because I thought it was gravel, I thought I was going to go see a dermatologist and they were going to remove it out of my skin, and that would be that. I had no thoughts about skin cancer.
So you had clear margins during your Mohs surgery, correct? Is that right?
So I had a wide excision surgery, so it's a little bit different than Mohs, but yes.
So at that time, how did you feel about the possibility of a recurrence, and what did they say about that possibility?
I really didn't even think about it because I thought that would just be something on my skin showing again. I did not know that it could come back inside of my body like that. And so I thought I could prevent it by wearing sunscreen, wearing my sun protective clothes, wearing my hat when I go outside, all of those things. So recurrence was not a thing that I thought much about.
And this is why I love sharing your story, because I would imagine that's what a lot of people are thinking. When they think skin cancer, they're thinking of the skin, and that's how they're protecting themselves. So let's fast forward an entire decade later, 2018. You felt that tender spot in your armpit. How did you learn it was melanoma again?
I went into my OBGYN thinking that it would be breast cancer. And so she sent me to get an ultrasound. And at that point, the radiologist came into the room during the ultrasound because he was concerned about it. And particularly when he found out that that was the same arm where my melanoma had been. I thought he was a little bit crazy because, again, I had no idea that that could be connected. So that's how I found out. The radiologist ordered a needle biopsy. And so they went in and pulled some of the fluids and tested it, and turned out to be melanoma.
And I would think that when you would feel that lump in your armpit, as a woman, I would think breast cancer as well. You'd had this cancer before, and now you're thinking another cancer would be breast cancer. So right. I want to ask Dr. Coram, when Ashley first came to see you on that recurrence, what did her scans and her biopsy show in terms of staging?
Right. Well, the biopsy did show melanoma. Knowing the way that melanoma behaves, I was hopeful that this was just a local or regional recurrence. That was the same arm, the same side of the body where the original melanoma was. And we know that melanoma can travel through lymphatic channels to local or regional lymph nodes. So I was hopeful that that was the end of the story. Ashley had a PET scan, a whole body PET scan, and an MRI of the brain to try to determine if there were any other sites of disease. And thankfully, I know there was just minimal uptake in the axilla or the armpit, but we didn't see other sites of involvement. So we were hopeful that with surgical removal and potential additional therapy, in this case, immunotherapy after surgery, that would be the end of this problem.
But Dr. Coram, I have to ask you, would it be a natural leap for someone in Ashley's case, as I had mentioned, to think that that was some type of breast cancer when you're feeling a lump in your armpit, and to go to your female doctor to ask to be checked for breast cancer, and to be confused a little bit?
No, that's very reasonable. That is the way that breast cancer can manifest in some cases, is a lump in the axilla or the armpit. So that was a very reasonable thing to consider. But again, knowing the way that melanoma can behave, and knowing that melanoma can sometimes show up years or even decades later, that was also, a concern or a suspicion, at least on our part. But that was a very reasonable thing to do. The good news is either way, someone's going to investigate that lymph node and get a biopsy. And if it turns out to be breast cancer, go down that path. In this case, recurrent melanoma.
Well, we spoke with Dr. Gary Doolittle, a melanoma specialist here at the University of Kansas Cancer Center, and he explains the different kinds of skin cancer and why melanoma is the most serious.
Most skin cancers are easily controlled by removing them surgically. So a basal cell carcinoma or a squamous cell carcinoma, you can remove surgically, and 99 times out of 100 you're not going to have trouble with it again. Part of the challenge with melanoma is the unpredictable nature of it. It is the classic, what's predictable about melanoma is unpredictable. Some will progress rather slowly over time, even in a matter of months. Some patients will have rapid progression in a matter of weeks. So again, it's that early detection and trying to prevent that spread. But once it's spread, early access to the healthcare system to get in and get the treatment started as quick as possible.
Treatment for this first recurrence involved removing lymph nodes. Ashley, you shared a photo of the incision shortly after your surgery. Then you started immunotherapy. Dr. Coram, what was the purpose of the immunotherapy?
Right. Well, melanoma is an unusual disease. It has a unique biology. We've known for many, many years, decades, that melanoma has a certain relationship with the immune system. And we certainly have had patients that we've recognized for some time whose own immune system, in the absence of any external therapy, their own immune system will control their disease sometimes for many, many years. So, there's a known relationship there, and it's become clear in the last, 10 to 15 years that immunotherapy with drugs that are now available to stimulate the person's own immune system has the ability to rev up the immune system and improve the immune system's ability to recognize melanoma cells and eliminate them. So, in Ashley's case, after she'd had surgery to remove those lymph nodes from the armpit, and we knew there was no other evidence of disease, we do have clinical trials that show that people in that scenario with stage 3 or local regional recurrence after surgery can significantly benefit from immunotherapy, which reduces the risk of recurrence and improves the likelihood that they will ultimately be cured.
Well, we have talked a lot about immunotherapy on this program because it really is a huge change in how we treat cancer. And here's Dr. Gary Doolittle again on how immunotherapy has changed patient outcomes.
Immunotherapy for melanoma has really changed the landscape remarkably. I mean, when I first met patients with melanoma, or when I first started specializing in this, which would have been about 2006, we did not have good treatments for it. We had chemotherapy. At best, it could hold the disease at bay for a certain amount of time, but universally, patients that had disease that was widespread or stage 4 would die of the disease. Maybe 5% would live. Enter immunotherapy, the first in 2011, other agents in 2012-13, and you've taken a disease that has never really responded well to anything to a disease that you can actually get into remission. So it's been a revolution, and not only in the care of melanoma patients, but in cancer care in general.
Dr. Corum, I have to ask you, what has it been like to be able to offer immunotherapy as an option for your patients?
Well, it's been very exciting. When I went through my training, there was very little. Traditional chemotherapy does not work well for melanoma. We had a drug called interferon that we used for some time. A small percentage of patients would have a dramatic response, but most patients didn't benefit, and there was a lot of potential toxicity. But immunotherapy is often extremely well tolerated, and we now have patients with stage 4 disease, meaning melanoma that's already spread to distant sites. Average survival for that disease, when I started, was maybe 6 months or 12 months, regardless of what you did. And we have people with stage 4 melanoma now out many, many, many years, and some of them with no evidence of measurable disease, in people who started with liver involvement or brain involvement. So it's been dramatic, and it's been very, very exciting.
Ashley, you had been getting regular scans, and you had felt what you called scanxiety. You had that term, scanxiety. Tell us about that and how you were coping with that.
Yeah, so in the early years, I would get some anxiety leading up to it because you just didn't know what you were going to find. But as the years went on, that kind of waned, and it just became a routine part of what I was being asked to do. So Dr. Corum says, go get a scan. I go get a scan, and I don't worry because nothing had been showing up. So yeah, I was not very worried about it when it did come back. It was shocking.
Right, so it comes back again. This time, that last time, that 4th time was in your lung?
Yes.
What was that like for you?
Just shocking. I mean, there's no other way to say it, because I was having no external symptoms of having any sort of recurrence. And so when it came back, and it was a pretty significant size mass, it was about the size of a golf ball in my lungs. And, I was running, and I was doing things using my lungs and not having any trouble breathing. So it was very surprising.
Dr. Corum, let's kind of go back to what you were talking about. Help us understand the differences between immunotherapy when Ashley was at stage 3 versus the type of treatment you're going to use when you learn that it's at stage 4. Are they different types of immunotherapy?
Well, to some extent, yes. In 2018, we had a situation where there was a melanoma in the armpit and nowhere else that we could find, and it had been surgically removed, although we were concerned that there could be residual melanoma cells hiding somewhere. So at that time, we used a single-agent immunotherapy with what's called an immune checkpoint inhibitor, and that was felt to be sufficient. When Ashley had a recurrence in 2024, it was a very different scenario. She had this large mass in her lung. She had a couple of spots that were concerning in the liver. There was another area near the pancreas that was a concern. And unfortunately, we knew that we couldn't do anything surgically to remove all that disease. So we really had to focus on systemic therapy. Again, chemotherapy is not very useful for this disease. So once again, because it had been 4.5 years or so, we put our hope in immunotherapy. But this time around, I wanted to use a combination of 2 different immunotherapy drugs that have 2 different mechanisms of action to see if we could really boost the immune system even further to create a deeper, better remission, improve the response rate. And we do see improved response rates with combination immunotherapy, but we also can see increased toxicity. But we felt in Ashley's case, she's young, she's healthy. We wanted to go for the best response possible. So we used that combination as sort of an induction strategy. And then once we saw a very nice response, we were able to sort of back that off to a single agent maintenance type treatment, which she's still receiving.
Ashley, what's any side effects? Any side effects did you experience?
I had very mild side effects in the beginning, maybe some tiredness and a little bit of inflammation type responses, but I did get shingles during treatment. Ooh. And then at the same time that I had shingles, I lost my adrenal function. So I'm adrenal insufficient and will be dependent on steroids for the rest of my life now.
Dr. Corum, is shingles something that happens, or was that just something that happened to Ashley?
Well, shingles is essentially the chickenpox virus, right, that comes out on the skin and manifests itself many years later. And that can happen in any kind of really stressful scenario. So when the body's under a lot of stress, for whatever reason, shingles, can happen. And I think that was the situation here. As far as the adrenal problem, that is a known potential adverse effect of immunotherapy. Sometimes the immune system can get a little overexcited when it's stimulated by immunotherapy drugs and create problems. So we did have to deal with that with some steroid replacement therapy.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Ashley's most recent scans show no evidence of disease. Dr. Corum, in clinical terms, what does that mean?
Well, no evidence of disease means that radiographically, on all of the scans, on all of our tests, we don't see any active cancer. So obviously it's really exciting when we get that. And, that was the case here. We do see that, from time to time with melanoma. We can see that sometimes in other diseases that are responsive to immunotherapy, like kidney cancer. But when we get it, obviously it's a great thing. So I was thrilled for Ashley.
What does her follow-up look like?
Well, obviously we're very happy with where she is. But I think, it's premature, obviously, to declare total victory here. Obviously, she went a decade before this thing showed itself before. So we're still being very vigilant. She is having regular visits. She's getting monthly infusions of the ongoing immunotherapy as a maintenance treatment. And then we are doing scans every few months of the whole body and then periodically of the brain, just to monitor to make sure this thing is not trying to work its way back.
Well, we asked Dr. Gary Doolittle the best way to prevent melanoma. Here's what he said.
I always worry about patients when they're diagnosed because very quickly they turn it on themselves and they say, I had too much sun exposure. I was a sun worshiper. I went to sun tanning booths and everything. And it's true that we want to limit sun exposure and we want to protect ourselves from UV radiation. Sun protective clothing, sunblock, sunscreen, hats, sunglasses. Just take care of yourself, but have some fun, enjoy. I'm not giving up my Saturdays at the lake. And I tell you, I'm a sunburn waiting to happen. I go and I just, protect myself from the sun and enjoy it at the same time.
And Ashley, you've become quite an advocate. You shared some photos of your work with the local nonprofit Outpacing Melanoma. What kind of work have you done with them?
I try to go to the annual 5K that they hold every year, and then they host some special events throughout the year. And I'm a busy mom, but as my schedule allows, I'll go and try to help out with their events.
What are some advice, tips that you have for people who might not take sun safety seriously?
It's just not worth it. It's like Dr. Doolittle just said. You can wear sunscreen, you can wear sun protective clothing. There's so many options out there. They're very comfortable. They keep you cool in the sun. Just cover yourself up.
Let's get to some questions from our viewers this morning. Becca wants to know, what is the likelihood of Ashley's cancer coming back? Dr. Corum?
Well, I think that unfortunately there's a high likelihood of that occurring. Obviously, we are working to prevent that and delay that as long as possible. Already a year and a half has gone by, and obviously we're looking for many, many more. But again, we'll have to remain vigilant.
Stuart wants to know, when are lymph node biopsies done? Was there one done during Ashley's first surgery?
Well, lymph node biopsies for melanoma are typically done when the melanoma is of a certain depth. So when we talk about melanoma, we have a staging system that's based on the depth of invasion into the skin. Believe it or not, typically we sample lymph nodes when a melanoma is more than 1 millimeter in depth. That's still quite shallow, but we know that the risk of lymph node involvement goes up beyond that. So that's the typical trigger for lymph node sampling.
Dr. Corum, last question, and we touched on this just a little bit, but before immunotherapy was available, what were the options to treat melanoma that had spread internally?
Right. Well, it was a difficult disease, and it was kind of a dismal time for everyone, most of all for the patients, but to some extent for their doctors too, because we weren't helping these people very much, right? We had traditional chemotherapy where we could occasionally get responses, that would last a few months, or maybe someone who would get a response for a year or so, but, that wasn't the norm. People with stage 4 melanoma, typically didn't live a year. We had a drug called interferon, which is sort of another way to stimulate the immune system, but not that great. That's associated with a number of side effects, and a small percentage of people had dramatic responses with interferon, but again, small numbers. So it really was not a good time 10, 15 years ago in the treatment of melanoma. So it's been, as Dr. Doolittle said, it's been a real revolution, immunotherapy, combination immunotherapy. And now we have, beyond immunotherapy, we have certain targeted drugs if melanoma has a particular mutation. So things are getting better all the time.
Dr. Corum, thank you so much for your insight this morning. What's the big takeaway today?
I think the big takeaway for me is that cancer therapy is changing, right? If you've heard me on this program before, you've heard me say this before. But people hear cancer, they think chemotherapy, they think nausea, vomiting, hair loss. I'm going to be sick. I'm going to feel terrible, and in the end, it's not going to make any difference. But this is a new era. We have targeted therapies, we have immunotherapy, we have certain cellular therapies for certain diseases. So the treatment of cancer has become very, very exciting, and we're making a bigger impact than ever with fewer side effects than ever. So that's my take-home message.
Ashley, what do you want people to take away from your personal story?
I just want people to have hope. I mean, obviously prevention is the best that you can do to prevent the skin cancer in the beginning. But if you find yourself with an advanced melanoma diagnosis, have hope. There are options out there, and we hope that they keep evolving and that the cure is around the corner.
Well, thank you, and please keep sharing your story with others. Makes a difference. And we want to share one final thought from Dr. Gary Doolittle on the progress that is being made in treating melanoma.
I almost envy our fellows as they come in to train now, because they consider this like any other any other form of therapy that we have, and they don't recognize like this was one of the huge changes in my career, not only for melanoma but for cancer care across the board. Yeah. And that's why it's so great to be an oncologist in 2025. It was great to be an oncologist when I started in 1991, but it's amazing right now, the advances, unbelievable.
Thanks to all of our guests this morning, and thanks to our viewers for being with us today. Have a great weekend. And before we go, it is Crucial Catch Weekend at Arrowhead, one of our very favorites. Crucial Catch is the annual NFL initiative for the prevention and early detection of 7 screenable cancers. And one of our patients, Renee Casey, will be there. She is a stage 4 lung cancer survivor, and we were with her as she found out she's going to the game.
Hi, Renee. I'm Drew. I'm one of the linebackers with the Chiefs, and we just wanted to honor you with 2 tickets to our Crucial Catch game against the Detroit Lions, and you're going to get to beat Patrick to the punch and throw out the first pass during this game. All right. And so thank you for your testimony and your story, and I know you're encouraging and inspiring a lot of people, but we're really excited to have you.
Yep, you heard Drew. Renee will be throwing out the first pass on Sunday as the Chiefs host the Detroit Lions. Dr. Blaine Knox, Renee's medical oncologist, will also join her on the field. Renee has no evidence of cancer right now, and she is doing really well. Well, it is a busy weekend for cancer prevention as the Leukemia and Lymphoma Society is hosting Light the Night Sunday, October 11th at Cleveland University. Light the Night's mission is to celebrate, honor, and remember those touched by blood cancers. Coming up Monday on the Morning Medical Update. She's a young mom of 4, and breast cancer wasn't part of the plan. Now she's driving nearly 6 hours for treatment and hope. I'm Jessica Lovell on the next Morning Medical Update. Why one mother says her health is worth the drive. Monday at 8.